So welcome to the Geriatric Grand Rounds. I'm Devin Gilhooly. I'm one of the physicians in the seniors clinic. I'd like to introduce our speaker today. It's Dr. Susie Kim. She is a PGY2 geriatric pharmacy resident at the VA Eastern Colorado Healthcare System. Our title presentation today is It's Never Too Late to Quit Tobacco. Just a quick announcement, the next Grand Rounds will be April 7th. Our speaker will be the geriatrics fellow, Dr. Thomas Johnson. Our next journal club is April 14th, and the geriatric fellows, Thomas Johnson and Mira Melton, will be presenting then as well. Other announcements: following today's rounds, you'll receive an email with a link to the online evaluation. Please complete that if you have an opportunity to do so. And please submit questions. Excuse me. Please submit questions in the chat or Q&A boxes anytime during this presentation. So to introduce Dr. Susie Kim, she received her PharmD from the University of Colorado Skaggs School of Pharmacy in 2020 and went on to complete her first-year general pharmacy residency at the VA Eastern Colorado Healthcare System. She is now finishing up her second year of residency specializing in geriatrics with the hopes to continue to care for veterans at the VA afterwards. Thank you, Dr. Susie Kim, for being here, and I will turn the floor over to you.
Thank you so much for the introduction, Devin. Like you mentioned, the title of my presentation today, It's Never Too Late to Quit Tobacco. So I do not have any conflicts of interest to disclose in relation to this presentation. And my objective today are to decrease the negative, to describe the negative impacts of tobacco use, including the risk for dementia, discuss the benefits of smoking cessation, compare and contrast the pharmacotherapy options for smoking cessation and also smokeless tobacco cessation. And lastly, to recommend appropriate therapy based on patient-specific factors in the form of a patient case. For this presentation, I will be focusing on the pharmacologic management of tobacco cessation and not so much on the behavioral interventions, but recognizing that the two together are needed for successful tobacco cessation. So I want to introduce this patient case since I'll be using it throughout the presentation to solidify some learning points. So JR is a 71-year-old male with a past medical history significant for hypertension, hyperlipidemia, PTSD, OSA, seizure disorder, and GERD. He is a current tobacco user. He does not have any teeth remaining and wears full dentures. The current amount that he smokes is about 1 pack per day, and his length of use has been a long time, about 45 years. Past smoking cessation attempts include just quitting cold turkey and some NRT products, including the patch, gum, and lozenge. And then when asked about number of serious quit attempts, he had mentioned that there are too many to count. So I'll start off with some background information. So cigarette smoking is the leading preventable cause of death and disability in the United States. There have been more than 480,000 deaths every year in the United States that are caused by cigarette smoking, which is equivalent to about 1 in 5 deaths. You can see on the figure on the right of the slide the breakdown of the causes of death. And the risk of death dying from cigarette smoking has increased over the last 50 years. As we all know, cigarette smoking has many negative health consequences, as you can see in the figure on the right. We know that it increases the risk of coronary heart disease by 2 to 4 times, stroke by 2 to 4 times, and lung cancer by 25 times in both men and women. Significant risks also exist for smokeless tobacco products, so things such as chew, snuff, dip, snooze, and dissolvables. I included some pictures at the bottom of this slide for those of us that are not familiar with some of these products, but these products can also cause cancer of the mouth, esophagus, and pancreas. It can also cause diseases of the mouth, early delivery and stillbirth when used during pregnancy, and also increases the risk of death from heart disease and stroke. Fortunately, we've seen a large decline in current smoking rates since 1965. The smoking rate in the 1960s was actually as high as 52%. And as of 2017, it's dropped down to 15.8%. These declines have been attributed in part to the progress made in smoking cessation efforts. I will talk specifically about the prevalence in the veteran population since this is where I'm practicing. So as of 2021, 55.5% were ever smokers, so a combination of former smokers and current smokers. 12.9% were current smokers. 5.1% used smokeless tobacco, and 3.8% used e-cigarettes or another vaping product. 49.3% of current smokers had made a recent quit attempt, but they were actually unsuccessful in doing so. And then only 35.8% of those unsuccessful quitters used a non-nicotine prescription or nicotine replacement therapy, also known as NRT, to help with their quitting attempt. When broken down by age groups, you can see in the 65 years and older group, which is the column on the very right and the column that we're most interested in, is that there are roughly 400,000 current smokers. 190,000 of them were recent unsuccessful quitters, with 38,000 being able to successfully quit. Although we've made great strides in reducing current smoking rates, we definitely still have progress to be made. There are significant health benefits to quitting, which is summarized on the screen here. In the first 24 hours, nicotine levels in the blood drop down to 0. Within several days, carbon monoxide levels drop down to a level of a non-smoker. In 1 to 12 months, coughing and shortness of breath decreases. In 1 to 2 years, the risk of heart attack drops significantly. The added risk of coronary heart disease drops by 50% in 3 to 6 years. The added risk of mouth, throat, and voice box cancers drops by half, and the risk of stroke decreases at that 5 to 10 year mark. At 10 years, the added risk of lung cancer drops by half, as well as the risk for bladder, esophagus, and kidney cancer also decreases at this point. At the 15-year mark is when we see that the risk of coronary heart disease drops close to that of a non-smoker. And then at 20 years, the risk of several different types of cancers that are listed on the screen here also drops to the level of that of a non-smoker. When caring for older adults, it's important to convey that quitting has benefits at any age. A smoker who quits after the age of 65 can add 2 to 3 years to their life expectancy. And then smokers who quit after the age of 60 have better lung function than those who continue to smoke. Although some of our patients may not reap the benefits seen at 10, 15, or 20 years of cessation, there are still plenty of short-term benefits of quitting, as I mentioned on this slide and the previous slide. I want to spend some time talking about smoking and dementia and some recent evidence that has been published. There is a misconception among some patients that smoking is protective against Alzheimer's disease. There were some studies that were published that reported this conclusion, but in a meta-analysis of the studies looking at the relationship between smoking and dementia, found that if the study was affiliated with the tobacco industry, it was more likely to result in a protective odds ratio. So when you control for industry affiliation, the study found that current or ever tobacco smoking was a significant risk factor for developing Alzheimer's dementia. In this, another meta-analysis of 19 prospective studies, they compared different groups of smokers, so current smokers, former smokers, and never smokers, on the risk of developing varying types of dementia. So the results of this study are as follows. Current smokers compared to never smokers had a 1.79 times increased risk of developing Alzheimer's, 1.68 times increased risk of vascular dementia, and 1.27 times the risk of what they consider just any dementia. When looking at former smokers compared to never smokers, former smokers were actually not at an increased risk. However, they did find a higher rate of cognitive decline for those that were former smokers. Lastly, when comparing current smokers compared to former smokers, they had a 1.7 times increased risk of Alzheimer's, but no difference in vascular dementia or any dementia, which is interesting compared to the results of a never smoker, which I'll talk a little bit more about in the next few slides. The risk of dementia also increases based on how many cigarettes are being smoked on a daily basis, as you can see on this graph depicting a dose-response relationship. The risk of dementia increases by 34% for every 20 cigarettes, so for every pack of cigarettes, which is a significant increase in risk. There are two large studies that I want to talk about that looked at smoking and quitting and its effect on incident dementia. This was a retrospective study that included 13,000 participants ranging from 52 to 75 years old with an average age of 63 years old. The results are depicted in the figure on the right, and it showed that current smoking and recent cessation, which was defined as quitting less than 9 years ago, were associated with an increased risk of dementia over a 12-year period, which was defined in the study. Although recent quitters still have an increased risk, it actually decreases by 24% after quitting compared to current smokers. This second study included about 10,000 participants aged 45 years and older. And what's unique about this study is that they included nursing home placement as a surrogate for undiagnosed dementia. I've highlighted the statistically significant results here on the screen. Compared to never smokers, current smokers were at a 1.7 times increased risk of developing dementia, which is pretty similar to the results that we've seen in the last couple of studies. But they were also at a 3 times more likely to die and 2 times more likely to die after getting dementia, which highlights kind of the importance of quitting even after a dementia diagnosis. And these results were actually irrespective of pack year history. So looking next then at the former smokers, they were actually less likely to get dementia, but this was primarily driven by former smokers that had quit over 30 years ago. So this was a result that was not expected. Authors thought that this could have been related to lifestyle modifications along with tobacco cessation, which may have contributed to this decreased rate of dementia. However, it did not decrease the risk of death or death following dementia compared to never smokers. These results conclude that current smoking actually matters more than the cumulative smoking exposure. Recent quitters, which is those that quit less than 10 years ago, did not have a difference in dementia risk compared to never smokers. And for the risk of death, it actually took 10 years for those results to be comparable. So in summary, smoking increases the risk of dementia, specifically Alzheimer's disease in the new data that we've seen. Previous studies that have shown protective effects were more likely to be affiliated with the tobacco industry. And if you increase the number of cigarettes smoked per day, it does increase the risk of dementia. And lastly, the risk for dementia is better attributed to smoking recency than lifetime exposure. So let's go back to our patient case. When asked if the patient is interested in quitting, he states, "What's the point of quitting now if I've been smoking for this long?" In this case, the question is asking, what are some short-term benefits to quitting that can be communicated to this patient? So based on what we've learned so far, he can be told that coughing and shortness of breath can improve in 1 to 12 months. His risk of heart attack decreases after 1 to 2 years. And then based on the studies we just reviewed, the patient can have a decreased risk of developing dementia since smoking recency and not cumulative smoking exposure increases the risk of dementia. I'm sure that many of us have heard about the 5 A's approach. It's the 5 major steps to intervention that helps us identify users and appropriate interventions based on the patient's willingness to quit. Smoking status should be evaluated at every visit, and patients should be advised to stop at every visit as well. It's been shown that even brief counseling of just less than 5 minutes at each visit has been shown to increase smoking cessation rates. Once we've identified smokers that are ready to quit, the following things should be recommended, such as setting a quit date, avoiding passive recommendations, addressing barriers to quitting, discussing nicotine withdrawal symptoms and setting those expectations over the next couple of weeks, providing behavioral counseling and pharmacotherapy. And after completing these tasks, follow-up should be arranged to monitor response and provide support and reinforcement. When setting the expectations for nicotine withdrawal, the following information should be discussed. So most symptoms occur within the first 1 to 2 days. They should peak within the first week or so, and they should subside within 2 to 4 weeks. And those symptoms specifically are irritability, frustration, anger, difficulty concentration, and different effects on mood, such as depression, and can affect sleep as well. The last 3 symptoms that are listed on the slide here, which are increased appetite, weight gain, and cravings, can actually persist for several months after quitting. So ensuring that patients are aware of the specific symptoms that can occur and when they should expect those to go away. Many patients are concerned about the weight gain that can occur after quitting, but thinking about the risks associated with continued smoking far outweigh the risk of weight gained. So let's talk about treatment options, and it's important to talk about the non-pharmacologic options for smoking cessation, but like I mentioned in the beginning, I won't spend too much time on this since it's not my area of expertise, so I'll focus more on the medications later on. Behavioral counseling is aimed towards providing education on withdrawal symptoms, identifying triggers, developing problem solving and coping skills, stress management, and relaxation techniques. Counseling, in addition to medications, is the cornerstone of smoking cessation, and both should be offered to patients that say that they're ready to quit. Here are some resources that I wanted to share, and also some VA-specific resources as well. I did want to say for the VA tobacco cessation quit line, spouses of veterans that also want to quit can use that quit line as well, so that they can quit along with their partners. Also, with the patient's permission, you can call the quit line on behalf of the patient, and they can reach out proactively. This is to avoid giving a passive recommendation, such as you can call the quit line when you're ready, which most patients don't have the motivation to do so on their own if they're not ready. So calling on behalf of the patient, having the quit line reach out to them proactively is a great option. You can also consider tapering nicotine in the following ways. So patients can purchase and smoke cigarettes with less nicotine content, and I'll share some more information about that on the next slide. Avoiding smoking a full cigarette is another option, so such as stopping after a half or a fourth of the way in. Switching to non-menthol cigarettes. Menthol actually may create a stronger nicotine dependence. Luckily, the FDA is currently working on banning menthol from cigarettes, which is a long-awaited action. And then lastly, for the smokeless tobacco users, they can mix their current supply with non-nicotine products to help kind of cut down and taper down on the nicotine. So here's a table of nicotine content per cigarette brand. So as you can see that there are brands that contain a higher amount of nicotine than others. Therefore, when thinking of a nicotine tapering strategy, you could consider switching to a brand and a type of cigarette that has less nicotine. I now want to talk about the pharmacologic options for smoking cessation. So first, we'll talk about nicotine replacement therapy, which I'll refer to as NRT from now on. These agents work as an agonist to the nicotinic cholinergic receptors to relieve withdrawal symptoms. Multiple formulations are available at this time, including the patch, gum, lozenge, inhaler, and nasal spray, with the patch being the only long-acting formulation at this time. There are a few precautions to NRT, such as recent myocardial infarction, meaning within the last 2 weeks or so, serious arrhythmias, or serious or worsening angina. Here is a graph looking at the change in plasma nicotine concentration of cigarettes, smokeless tobacco, and then the different NRT products that are offered at this time. As you can see, none of the NRT products produce the same level of nicotine in the plasma as cigarettes do. This means that the NRT products, such as the gum and the lozenge, for example, are not going to produce the same, like, quote unquote, nicotine hit, which is an expectation that should be communicated to patients beforehand. I'll start with the nicotine patch, which is the only long-term NRT formulation. The starting dose is determined based on the number of cigarettes that are smoked each day. At the bottom of the slide, you'll see the recommended tapering schedule, but keeping in mind that durations longer than 8 to 10 weeks that are pre-specified in the tapering schedule may be required for some patients to achieve sustained smoking cessation. So these schedules can be individualized per patient. The patch should be applied to clean, dry, and hairless skin on the upper body that's properly secured for several seconds. It should be replaced daily, and the patch site should be rotated to avoid any skin irritation. When disposing of the patch, the sticky sides should be folded together and thrown away to avoid children, pets, or other people from handling that part of the patch that has the active drug. And what's nice is that this patch can be worn while swimming, showering, exercising, since it should be worn for a 24-hour period. A few clinical pearls with the patch include, so in regards to administration, the patch should not be cut since this can affect the way that the nicotine is delivered over a 24-hour period. They should be removed prior to getting an MRI. And then more than one patch can actually be worn at the same time to match the current nicotine intake to prevent any of those withdrawal symptoms, which I'll talk a little bit more about later on in this presentation. For patients that are experiencing skin irritation, such as itching, burning, tingling, ensure that the patient is rotating the patch site, so applying it to a different area each time. And they should be provided with education that symptoms such as like burning and tingling should usually resolve within the first hour. And if they have any itching or local skin reactions, you could consider an over-the-counter hydrocortisone cream if needed. Nicotine can cause insomnia or vivid dreams. In these patients, the patch should be removed prior to bedtime and then reapplied in the morning. There was a study that found that doing so, there was no significant difference in the quit rate when the patch is worn for, say, 16 hours versus the full 24 hours. You may consider proactively removing the patch prior to bedtime in patients with PTSD and if they're already experiencing nightmares or at a risk of having nightmares. Lastly, when the patient is not adhering or if it's falling off, you can use an occlusive dressing or apply a tape to help kind of secure it in place. The gum and the lozenge are both short-acting formulations that have similar dosing. So the initial dose really depends on when the first cigarette is smoked in the morning, whether it be within 30 minutes of awakening or after 30 minutes. The recommended dosing is listed at the bottom, which is also a tapering schedule of up to 12 weeks, but can be individualized per patient. Patients should be counseled on the correct use of the gum and lozenge to avoid having any of those side effects. For the gum, patients should not chew it like regular gum, but instead chew it until they feel like a peppery taste or a tingling sensation, and then park the gum in between the inside of the cheek and the gums until that sensation disappears. And then they repeat this step until it stops. The lozenge can be easier to use since it's just placed inside the cheek and the gums and should be allowed to dissolve slowly over a 20 to 30-minute period, keeping in mind that it's important that the lozenge should not be chewed or swallowed to prevent any of those side effects from happening. A few clinical pearls of these agents include avoiding eating or drinking within a 15-minute period before and during use. An acidic environment can affect the way that the nicotine is absorbed. So in order to have the most benefit from these medications, patients should avoid eating or drinking within 15 minutes. Chances of quitting are higher when these agents are used on a schedule versus on an as-needed basis. So if a patient is able to adhere to the schedule, they're more likely to be successful. Again, stressing the fact that these agents will not provide the same rapid relief that smoking does, so setting that expectation before doing so. And then nicotine is absorbed through the lining of the mouth, which is why it's important to counsel about the eating and the drinking portion. Using the gum and lozenge can lead to side effects such as dizziness, nausea, vomiting, other GI symptoms, throat irritation, and hiccups. And those side effects can be higher if these agents are used incorrectly. Lastly, specific to the gum, it may be difficult to use with dentures or patients with poor teeth. We then have the inhaler, which is actually restricted to the smoking cessation clinic here at the VA. The dosing is 1 cartridge every 1 to 2 hours with the recommended starting dose of at least 6 cartridges per day during the first 3 to 6 weeks, with the hopes of gradually reducing the dose over the next 6 to 12 weeks. Each cartridge should allow for about 20 minutes of active puffing. And what's nice about this device is that it mimics that hand-to-mouth behavior, similar to what you would do with a cigarette. I won't go into too much detail on how to use this device, but the inhaler itself is reusable, and the cartridge that's inserted into the inhaler is what's replaced each time. And so you can see the graphic on the screen here that shows you the different parts of the inhaler. For patients that are started on the inhaler, they should be provided with thorough counseling since it's often used incorrectly. So patients should avoid deep inhalations and should instead inhale in short puffs so that they get the medication into the back of their throat and not into the lungs. The nicotine is not absorbed in the lungs, but instead absorbed through the oropharyngeal mucosa. Side effects include irritation of the mouth and throat, cough, GI symptoms, but these symptoms should improve with continued use. Since the inhaler is reusable, the mouthpiece should be washed with soap and water regularly. And then similarly with the other short-acting NRT products, patients should not eat or drink within 15 minutes before or during use. And using the inhaler in cold temperature should be avoided since this can actually compromise the nicotine delivery. The nasal spray is the last NRT product, and here at the VA, this is also restricted to the smoking cessation clinic. What's unfortunate about the dosing of this product is that each dose is 2 sprays in each nostril, and the recommended starting dose is at least 8 doses per day for the first 6 to 8 weeks. So it does require a lot of sprays. The hope is to then gradually reduce the dose over the next 4 to 6 weeks or so. This works like any other nasal spray device, so patients should be instructed not to sniff or inhale while spraying the medication. If they feel that the medication is running out of their nose, they can gently sniff to bring it back up, and then they should wait a few minutes prior to blowing their nose afterwards. The side effects of this medication can include coughing, runny nose, and irritation, which should improve with continued use. And then if a patient accidentally sprays it in their eyes, they should rinse with water immediately. Next, I'll move on to the non-nicotine products. So starting with Bupropion, its mechanism of action is through noradrenergic and dopaminergic effects to actually decrease symptoms of withdrawal, but also decrease cravings. This medication should be started about 1 to 2 weeks prior to the quit date, and the dosing is listed on the screen here with some dose adjustments, whether the patient has any renal or hepatic impairment. Bupropion is contraindicated in patients with a history of seizure disorder, anorexia or bulimia, or those that are taking concomitant MAOIs, and those undergoing abrupt discontinuation of things such as alcohol, benzos, barbiturates, and anti-epileptic drugs. The most common side effects to counsel about this medication include insomnia, dry mouth, and nausea. And then some of the less common side effects can include anxiety, constipation, tremor, and skin rash as well. Varenicline, also known as Chantix, is our last agent, which works as a partial agonist at the nicotinic receptors, which blocks nicotine from binding to the receptors, and so overall helps to reduce withdrawal and cravings. Dosing should be started as a titration to avoid GI side effects. Similarly to bupropion, patients should start Varenicline 1 week prior to their quit date. I also included the dosing of this medication at the bottom of the slide with dose adjustments and renal impairments, and no dosing recommendations are recommended for hepatic impairment. The most common side effects for this medication include nausea, insomnia, abnormal dreams, and headache. And then the less common ones are alteration of taste, constipation, and flatulence. This medication should be taken with food and a full glass of water, but also educating that the adverse effects should be improved with continued use over time. Unfortunately, there was a voluntary recall of Varenicline in July of 2021 due to the presence of an impurity that actually exceeded the acceptable limit as defined by the FDA. The FDA did say that there's no immediate risk to patients that are taking the medication, but at this time, we're still waiting for this to become available again for our patients. More recently, there is a company that is working with the FDA to temporarily import Varenicline from Canada, but updates are still pending regarding this transition. When I looked on the FDA website a couple of days ago, they still didn't have any updates at this time. When talking about bupropion and Varenicline, it's important to talk about the previous black box warning that was on these agents due to the risk of neuropsychiatric events such as depression, aggression, and hostility. This warning was removed in 2016 after a large trial called the Eagles trial that included 8,000 patients, found that there was no significant increase in neuropsychiatric adverse events due to either of these agents. When thinking about why those neuropsychiatric events had occurred, many people smoke to relieve depression and anxiety symptoms. And so if you take away the smoking, it can lead to an increased risk of those mental health symptoms. So as long as the patients are stable, they are still really good candidates for Varenicline. After discussing the pharmacologic options, let's go back to our patient case. So the question here is, which pharmacologic treatment options would be appropriate for this patient? So we can definitely consider a nicotine patch for this patient, but might consider removing it before bedtime if the patient already has nightmares, given his PTSD diagnosis. Nicotine lozenge is also an option. The inhaler and the nasal spray can be considered to this patient, but keeping in mind it's restricted to the smoking cessation clinic here at the VA. So this patient would need to be enrolled with that clinic in order to get those medications specifically. Varenicline is a great option for this patient. And then nicotine gum, just a caveat, is that it may be difficult to use in patients with dentures, so could likely avoid in this patient. And then bupropion should be avoided due to the history of seizure disorder. And so how do these treatments compare to one another? So in a meta-analysis of 12 Cochrane reviews, the most effective treatments were shown to be combination NRT, which includes both long-acting and short-acting products, and then Varenicline when compared to placebo. You can see that the odds ratios have been listed from lowest to highest. Here is the VA treatment algorithm for smoking cessation, in which the recommendations are also driven by cost for us here. So the first line treatments are NRT monotherapy, bupropion, or combination NRT, so a combination of both long-acting and short-acting. If the patient fails 2 out of these 3 therapies is then when varenicline can be considered for our patients. I also wanted to share the recommendations included in the 2020 American Thoracic Guidelines on the treatment of tobacco-dependent adults. So I just included their primary recommendations listed on the screen here. So their recommendations include initial treatment with varenicline over nicotine patch or bupropion. As I just mentioned on the previous slide, varenicline is the most effective medication compared to the other agents. Varenicline in combination with the nicotine patch is actually suggested over varenicline monotherapy. There was a couple of randomized trials that looked at the efficacy of the combination of nicotine patch and varenicline and found that it was more effective than just using varenicline by itself. It is also recommended to start varenicline in patients that are not ready to quit, rather than waiting until the patient is ready to stop. Evidence has shown that more smokers were able to stop smoking when treated with varenicline despite their initial reluctance. So although patients may not be ready to completely abstain, they may be willing to try tobacco dependence treatment, and it may increase the number of patients who will go on to stop smoking. For patients with psychiatric conditions, varenicline is recommended over a nicotine patch. And then lastly, extended duration, so meaning greater than 12 weeks, is actually recommended over a standard duration, which for the most part is 6 to 12 weeks. If I could just have everybody mute, that would be great. Thank you. Lastly, I want to talk about treatment in smokeless tobacco. Smokeless tobacco products deliver higher amounts of nicotine compared to cigarettes, and it's estimated that chewing tobacco, when used 8 to 10 times per day, delivers as much nicotine as 30 to 40 cigarettes per day. There are currently no FDA-approved products for smokeless tobacco cessation, and the agents that we currently have on the market have pretty limited evidence in this setting, but the next couple of slides, I'll kind of discuss the evidence that we have so far. In a systematic review, it was found that NRT is often not as effective for smokeless tobacco cessation like we see with cigarettes, since nicotine is often under-replaced when the standard dosing is used. And so when specifically looking at the nicotine gum, it was effective for reducing kind of those short-term withdrawal symptoms, but when looking at long-term abstinence rates, it did not increase that compared to placebo. When looking at the patch, it did reduce those short-term cravings and withdrawals, but did not increase long-term abstinence rates similar to the gum. But the caveat is the patches that were used in these studies were using standard dosing, so up to 21 milligrams a day. The lozenge did show that it also increased or reduced short-term cravings and withdrawal. And for some reason, this product did increase tobacco abstinence rates at 6 months or longer, but keeping in mind that 3 out of the 5 trials did not use a placebo control. So high dose NRT patch was also studied. So in this first study listed here, a 21, 42, and 63 milligram dose of the NRT patch was used for patients that used at least 3 cans per week. And so in order to get these doses, you have to use 1, 2, and 3 of the 21 milligram patches. During the first week, the higher nicotine patches, so the 42 and the 63 milligram, were associated with less withdrawal symptoms, meaning that they had less of decreased arousal, negative affect, and restlessness. And then nicotine toxicity symptoms did not differ between the groups, but there was a higher rate of nausea in the patients that were on the 63 milligram a day, meaning they were on 3 patches per day. This second study looked at just 42 milligrams alone compared to placebo in the same population, so patients that were using at least 3 cans per week, and found similar results of higher efficacy, and they did find similar rates of side effects between the two groups. Bupropion has been studied, but showed that there was actually no difference in abstinence rates at 7, 24, and 52 weeks. However, it did significantly decrease the symptoms of cravings and weight gain over the treatment period. The first graph you see here is percent abstinence. So you can see by the end of the trial, it was pretty much the same. The middle graph is the rate of cravings. So it was better in the bupropion group. And then the last one shows the mean change in weight. And so the patients that were on bupropion didn't have the same amount of weight gain compared to placebo. When looking at Varenicline, the first study was able to achieve higher rates of continuous abstinence at weeks 9 to 26 compared to placebo. And then this effect was also replicated in another study when they looked at it for 12 weeks. And so along with all the other options that I spoke about, Varenicline was also associated with significantly less craving symptoms. So if we go back to our patient case, and instead of smoking cigarettes, this patient now uses smokeless tobacco, and he uses 3 cans per week, like I had mentioned in the previous slides. So which pharmacologic treatment options have been shown to be effective for smokeless tobacco cessation based on the evidence that we have so far? So based on the evidence that we have so far, nicotine lozenges seem to be effective compared to the other short-term NRT products. Another option could be a high-dose nicotine patch of 42 or 63 milligrams, which would require using more than one of the 20 milligram patch because we currently don't have a higher dose nicotine patch on the market at this time. And then lastly, another option would be Varenicline since it's been shown to be effective for sustained abstinence. So in conclusion, smoking cessation has benefits at any age. Current tobacco users should be advised to quit at every visit. Even just a few minutes of counseling has been shown to improve cessation rates. Behavioral counseling in combination with pharmacologic treatment is recommended to achieve sustained abstinence. And when choosing pharmacotherapy options, they should be chosen based on patient-specific factors such as patient preference, side effect profile, their ability to adhere to the medication, and then depending on what type of tobacco that they're using, whether it be cigarettes or any of the smokeless tobacco products that I mentioned. Thank you all for tuning in this morning. If anybody has any questions, I'd be happy to answer them at this time. Please feel free to enter them in the chat box.
Thank you, Susie, so much for that wonderful Grand Rounds presentation. That was excellent. It does look like we have a couple questions. The first one in the chat box is, what are the sex differences in smoking status and dementia, Alzheimer's risk?
Oh, that's a good question. In the studies that looked at smoking and risk of dementia, I didn't see any difference between men and women that was reported in the 2 studies that I looked at in depth. But outside of those studies, I am not too sure if there's a difference in gender at this time, but I can answer only based on the 2 studies that I had included in detail at the beginning of this presentation.
And similarly, Susie, were there any racial differences that you noted in smoking status and dementia?
Yeah, not that I saw in the two studies that were included. They really mostly just looked at kind of the timeline in smoking recency and then looking at the risk of dementia and death. So I didn't see any specific differences in race, but if I do any like further research and I see any differences in race and gender, then I'll definitely provide that information to this group.
All right, I don't think we have any more questions. Oh, there we go. Oh, yeah, just a thank you. Thank you so much, Susie, for giving a just wonderful Grand Rounds presentation. I think this is applicable to everyone. And thanks everyone for joining us this morning, and take care.
Thank you.